So in the interest of starting on time and not delaying people the rest of the day, and it's being recorded, we'll get started. Welcome to the APSA Workforce Committee breakout session entitled Training of Rural and General Surgeons to Improve the Care of Children in Underserved Areas. My name is Sam Alaish, and I'm the chair of the Workforce Committee. And to my left is our vice chair, Dr. Abigail Martin, and we will co-moderate the session. I want to give credit to all members of the Workforce Committee. Everyone has worked hard to put this together, and hopefully you'll learn something and enjoy the session. Despite an ever-increasing number of pediatric surgery fellowship graduates, an estimated 10 million children live more than 60 miles from a pediatric surgeon. The Right Child, Right Surgeon recommendations aim to improve the care of these children in underserved areas, and these recommendations include developing remote-based education and patient consultations using telehealth services, studying and providing guidance on which children can be cared for in underserved environments, define the scope of practice and develop the curriculum and educational process to meet this need, and focus training of rural and general surgeons to perform basic pediatric surgery cases and care for pediatric trauma patients where pediatric surgeons are not practicing. In this breakout session, we will shed some light on all of these areas. We will begin by examining the use of technology, including telemedicine, to remotely provide expertise. Our first speaker is our newly minted Robert E. Gross Award winner, Dr. Charles Stoller. From revolutionizing the care of babies born with congenital diaphragmatic hernia in the Children's Hospital of New York to being a private practice pediatric surgeon in Santa Barbara, California, Charlie can do it all and has done most of it, all of it, except put a baby on ECMO at Cottage Hospital. But trust me, he thought about it. Always open to new ideas, Charlie has seized upon telemedicine to provide his medical and surgical expertise to providers all around the world through an organization named World Telehealth Initiative. I asked Charlie to share his experience with us, and I'm delighted he has accepted.
Good morning, and thank you, Sam, for that overly generous introduction. Sam was one of our fellows in New York, and after the meeting this morning, I can tell you what it was really like with him as a fellow, but I'll pause on that. How do I advance the slides here with this green button? Thank you. So I know this is a discussion about rural medicine. Oh, I have to disclosures. I retired from clinical surgery on January 1st, 2021. I can have that discussion too. That's interesting, not getting a paycheck anymore. I'm still pretty opinionated. I don't play golf. Coming from New York, I can tell you that the Red Sox still suck, and I don't have any disclosures to make. So yes, I've retired from clinical surgery, but I do other stuff. As Sam alluded to, I'm a physician consultant to the World Telehealth Initiative, which I'm going to talk about in some detail. A lot of my work is done through the Walter E. Kapp Center for Ethics, Religion, and Public Policy at the University of California in Santa Barbara. I still retain my Columbia title, and I do a lot of work with the Food Bank of Santa Barbara County, which donated and distributed 40 million pounds of food in the last calendar year. And with the acceleration of inflation, that's going off the wall again. And if you want, I can join you by Zoom for your M&M conferences. I love rendering opinions about patients for which I have no accountability. So what is this? I know we're talking about rural medicine. The bulk of the world is rural, and we'll detail some of this. The World Telehealth Initiative is a spinoff, is an NGO 401c3 spinoff from what began as Intuitive Medical. You may remember them. They built some of the early Zeus robots under the direction of Yulin Wang, and this evolved into InTouch Medical. It was actually based in Santa Barbara. They really recently were merged with a company called Teladoc, and this is the largest provider of telemedicine in the United States. For example, the way that Mayo Clinic communicates throughout the state of Minnesota is through their telemedicine robots. As I'll show you, these robots are not, the iPads you look at to do communication. These are very interactive devices. And if I have time, I'll try to demonstrate how that works. To put this in context, as Sam said, most children in the United States are more than 60 miles away from a pediatric surgeon. Most children in the world are miles away from a pediatric surgeon. The bulk of the world is lacking access to health care, and especially children. And when you look at the total global need for health care, it's about 15 million additional people are needed to meet the needs. So the mission of this initiative is to provide a sustainable medical expertise to these vulnerable communities, at the same time, building local capacity and deliver health care. Many of us have been on missions to other underserved areas to go there to do surgery. That's not what this is about. This is about leaving something durable as an educational process, teaching, leaving behind something that you don't have to go there every day for. It's also a way of using very high-end technology that I'm going to show you examples of with the volunteer physicians. I'm a volunteer. I'm not paid for this at all. It allows us to access under-resourced communities. Below are some of the logos of other organizations that are involved in this. This is almost exclusively in the adult world. The bulk of it is in the adult world. The bulk of it is in primary care. Although there is some psychiatry, which is interesting, doing it through another culture, and there is some pediatrics. And I'm the one that started the pediatric surgery part of it. So this is what it looks like. As I said, we're volunteers. I don't have a pointer, but that's actually me sitting at my laptop. I sit out by the pool behind my house and talk to people in Bangladesh and Malawi and the Amazon basin. But these devices are extremely interactive. I can zoom in, zoom out, put laser pointers. I can see the medical record. And the communications are very rapid. There's none of that lag because it's all a proprietary satellite communication with no fiber optics. So there's almost no lag. And at the bottom panel, I can see one of my colleagues teaching an endoscopy. He's got a fiber optic bronchoscope, and he's doing it on a mannequin. And you can see the people on the screen in the upper left-hand corner watching him do this bronchoscopy. So he's teaching them how to do a bronchoscopy. If they did a bronchoscopy on their end, we would see it simultaneously on our end and say, steer left, steer right, there's a foreign body, there's this, there's that. So it's a very interactive system. As I said, this allows peer-to-peer training. The physicians on the other end are terrific. These are highly motivated physicians, largely trained in Europe, some in the United States, and mostly in Europe. Many are trained in France. Some are from a couple from Great Ormond Street, but very motivated. Their English is excellent, although we do provide simultaneous translation to whatever language is necessary. What I do primarily are clinical consultations. I'll have a pediatric surgery clinic once or twice a month, and they'll have patients lined up, and the mother will be there with the baby, and I can see what it is. It's a hernia. About a month ago, they had a kid with a cloaca. Showed them how to evaluate that, how to do this, and how to do that. And then when they took the kid to the OR, I guided them through how to do a colostomy for the kid with a cloaca, for example. The surgical part, I'll show you a picture of the intraoperative device. It's called Visitor One. This is a device that you can move into the OR, and with laser pointers, and you can actually see the telescopes from the laparoscopy, everything simultaneously. And this is how, for example, we learned in New York how to do thoracoscopic lung resections with Steve Rothenberg while he was in Denver. So that's how we took that and scaled it up to an international activity. The high acuity care, that's not a great photograph of it, but this is something we talked about earlier in one of the earlier sessions during the meeting. They say there's a newborn needs resuscitation. They're in a remote hospital, a rural hospital. So they call us emergently. We have an on-call, ad hoc on-call system. We have a newborn. I can dial into them and we'll say, use a 3.5-minute tracheal tube. Here's how to set the ventilator, start the IV. We're on our way. This has had its most robust applications for stroke patients who are remote. Start the anticoagulation, start the IV, and you can do a complete physical exam with these devices, especially a neuro exam. With deep learning and artificial intelligence, they can look at the eye grounds. There's enough information in the eye ground examinations to make a diagnosis from looking at the eye grounds. They're also being taught to recognize ganglion cells, which will have application for rural medicine. But we can initiate trauma resuscitation, neonatal resuscitation while the helicopter's on the way. So this has lots of applications. So how do we identify these international sites? Some infrastructure is needed. They need electricity, they need broadband, they need robust broadband access, they need running water, and they need physicians with whom we can communicate efficiently. The most important part of developing these programs is to identify what that community needs, rather than us, the Great White Hope, going to tell them what they need. We need to know what they need. So step one is we ask them, we can provide this service, what would you like it to look like? What kind of functionality would you like to be brought to bear? So once we get an input from them, then we design what services we can provide. There's some technical issues. As I said, we need to understand their broadband access. We understand there's some security. Malpractice is not an issue. We need approval from their government Ministry of Health. That's the MOH. The Ministry of Health needs to approve that we're doing this, and so forth. So there is a process to setting this up. The other issues that go around in setting this up is sort of what I call a matching algorithm. There's time zone differences. I was going to try to show you, I can actually show you what's going on in the Rohingya, the Cox's Bazars, or all the Rohingya refugees are in Bangladesh. And that's where I have my pediatric surgery clinic, but it's Monday night there now, so it's a 13-hour time difference. So we have to deal with time zones, who's available. The language issue, the patients generally don't speak English, but the doctors usually do. You may need some translation. Existing relationships are important. For example, in Bangladesh, the nearest city, if you will, is Doha. There's actually 2 international APSA members in Doha. And so when we identify, like, for example, this child with a cloaca, we got the colostomy done in the refugee camp, and then the kid was transferred. Then I contacted the pediatric surgeon in Doha, and he did the ongoing care for the cloaca. The diaspora is very important. For example, again, to use the Bangladesh example, in Miami, there is a pediatrician who's a Bangladeshi who has a pediatric practice in Bangladesh. He knows all the community. He knows the Rohingya community. He knows all the other NGOs in the Rohingya community, in the refugee camps. And he's part of the Rohingya diaspora, if you will. And so we take advantage of people from these remote communities that actually live in the United States to help with translation, help with understanding the culture that we're moving to. You know, for example, it's a very Muslim, devout Muslim culture. I'm Jewish. I have to figure that out. This is where the activities go on. So you can see this began just in Bangladesh, but it's pretty much worldwide now. And it's a very busy slide, but you can see the various functionalities he's developed at all these many sites. And you can see where, for example, in Bangladesh, that's where pediatric surgery is. In Central Africa, in Malawi, where is it on there? There it is down at the bottom. We also have pediatric surgery. That's been very interesting because, for example, they wanted to know how to treat obstetric fistulas, you know, complications of traumatic childbirth, which in that culture is unbelievably bad and very socially isolating. And they did not know how to do the surgery. So actually the obstetricians, they came from Baylor, and they zoomed in and we taught them, I didn't do this, they taught them how to do fistula repair to the point where we no longer need to go there. Remember I said we're trying to develop sustainability. So we taught their physicians with the intraoperative guidance how to do obstetric fistula repair so that we no longer need to do that. So now we zoom in to deal with the kids that are born there. So that's been a very nice evolution. The one that's in evolution now that's just beginning to emerge is in the Amazon basin. I listed under Ecuador, but that's going to be interesting dealing with indigenous peoples in the Amazon basin with these through telemedicine. These are what the robots look like. On the right is what we use for the office practice for consultation. It's a very streamlined. Everything plugs in. It's very interactive. Up at the top above the screen are these lenses that zoom in, zoom out, wide angle, short angle. As the broadband access makes the communication very prompt. On the left is the operative robot, because with that boom, we can look straight down into an operative field. And you can see there's the visual on the one panel with the cameras. On the bottom panel is the intraoperative telescope view. So we can guide them through an operation. I can't do the operation, but we can guide them through an operation with these devices. So I think that's as much as I wanted to show you today. Oh, this is the latest. This is what it looks like. This is a still photograph on the left of a simulation I'm going to try to show you. This is in the simulation lab that's actually in Santa Barbara, where we practice with the devices, moving them in and out. And that's a newborn mannequin in an isolette. On the right is the latest project that we're very excited about. We've made the observation that with the tragedies in Ukraine and all the internal migration and the immigration, that children are being pushed into Western Ukraine, into hospitals that are not used to seeing lots of children. And then general surgeons who are not used to taking care of children are being asked to operate on them. For example, the chief of surgery in Lviv is 34 years old and finished his surgery training at age 29. And so they're very highly motivated. But so what we've done is we've placed 11 robots. 8 of them are in Western Ukraine, 3 are in Poland. They're actually there in place a week ago. And we've been working with our Department of Defense and their Ministry of Health and Ministry of Defense. And what they said, what they need in addition to pediatric surgery, because these children, turns out like you've seen these kids getting off the buses. They're getting off the buses with appendicitis for 2 weeks and things like that. So this is a very difficult situation. But these kids are also involved in battle trauma, blast injuries, buildings collapsing on them. And so what they also need are pediatric surgeons that understand combat trauma. So in our organization, we've identified 15 pediatric surgeons that have been in Iraq, Afghanistan, Vietnam, Rick Pearl, for example, that all have this software now uploaded onto their PCs. They've been in-serviced. And we're about to go live with weekly elective clinics for lumps and bumps and so forth and so on. And then we have a call system that's being facilitated by the Department of Defense. So they have a kid with appendicitis or a kid with some combat trauma. We're on call, they call us, and we can advise them through that, through these telemedicine robots. So this is about to go live. Stay tuned, watch this space, as Rachel Maddow would say. So I think that's very exciting, especially if it works. We're also trying to augment this with pediatric anesthesia and pediatric critical care that they've asked for as well. As proof of concept, they said, let's see how this works. So we developed a series of lecture case presentations. And for example, 2 weeks ago, 4 military trauma surgeons talked about military combat vascular injuries. They gave a little talk about this, that, and the other thing. And there were more than 100 Ukrainian and Polish surgeons on the other side with simultaneous translation from English into Russian, Polish, and Ukrainian. And it was amazing. I mean, these folks, they sucked it up like a sponge. I mean, very highly motivated, very appreciative. And because we could show this rapid communication, they said, okay, let's do telemedicine robot activities. So that's what got us go forward on that. So I know my time's running short, but I just want to try to show you, if I can. This may or may not work. Can you switch over to my laptop, please? So I have to sign in. Everybody has a unique password. If I tell you, I have to kill you. Need to get in here?
Go ahead, sign in.
This is an example of because the broadband in this building is very slow. The stuff in your home is probably better. Okay. What am I going to do here? It's acting weird. It's going to make me sign off here. Here's what I'm going to do here. So I'm going to try to show you how this works, if it'll let me log in. This is just a simulation lab we have in Santa Barbara. So if I went into Bangladesh, it's nighttime there, and it's tomorrow. So this is what the interface looks like. The broadband here sucks. It's really slow. Okay, so you can see this is just a simulation. Here's the mannequin in an isolette, and you can see me. They can see me also. The monitor is at the foot of the bed. If you're looking at the monitor, you would see my picture. They would hear me talking. I would hear them talking, and then I can zoom in, zoom out. Say I want to see, it'll zoom in, and I can get really close to the baby. Now it's too far in, and so forth. Now I don't know how to zoom out. Usually you need a mouse to do this. All right, I don't have my mouse with me. I apologize. The baby's over here. There it is. So this is good. So if you're trying to teach somebody how to intubate, you can see the face like this. You can move these things they're motorized. You can move them around to the head of the baby so you can see what it looks like as you're intubating and guide them right through the intubation. So this is just a very brief example of this. If you're doing neonatal resuscitation, you show them how to put on the nasal prong CPAP, where to start the IV. For trauma, you can show them how to put the IO in, and so forth and so on. And it's recordable. You can take photographs. There's back and forth. As I said, the communication is very rapid. There's almost no delay because of the proprietary software. So I think I'm going to stop there. If there's questions or there's time, I'll be happy to entertain them. But I said this is an example. It's not rural like out in a farm in the United States, but it's rural like at the end of the earth.
Charlie, a quick question. Can you drive this thing around with a joystick remotely, or is all you can do is zoom the camera in and out?
So this particular, if you go to their website, you'll see all the different models. This particular one is stationary, but they make one that's drivable. You can drive it all over the hospital, drive it into the ICU, drive it into the OR with a joystick. You can drive it anywhere. This particular model is their simplest model. It's the least expensive one, and it's stationary. You can move it by hand. But the more advanced ones, like the intraoperative one that I showed you, that's steerable. You can move that around in the OR, for example. There's different models. Jeff.
Charlie, for an example like something elective, like you were saying, the obstetrical trauma and a fistula, will somebody go travel there for the first time it's being done there, or they'll just walk them through and say, retract here, put your stitches in here?
Right. That's one of the beauties. If any of you had an interest in doing, remote mission type surgery, it means you got to take time off work. It's expensive. Now you're working in an environment you're not used to. This gets away from a lot of that. So no, you don't go there. You guide them through it. You mentor them through the procedure. That's how this works. You don't go there. You can if you want, but they don't want you going to Ukraine unless you're part of Médecins Sans Frontières or Red Cross or one of those organizations. Do not go there. Max.
Charles, this is cool. Is there any kind of standard debrief so that people know what to expect going into a session like this before you do it, and then the learning opportunity in the back end where you kind of review the film? And
yeah, so like before a session, I'll get a list of the patients. The communications this is all encrypted when we do it internationally, and the text communications through WhatsApp, which is also end-to-end encrypted. And I'll get a list of the patients we're going to see and why we think they're seeing them. If there is any radiology, I'll get those in advance, so I'll have some idea what I'm getting into. We'll do the consultation, and then there'll be a debrief session at the end of that. I will send them a long text of, this is patient A, this is what we talked about, this is what I think, let me know what else I can do for you. So they'll get there's a pre-session heads up, and there's a post-session, this is what we did. Does that answer your question? Okay.
Thanks, Charlie.
Okay, thank you very much.
Amazing.
Appreciate the opportunity.
Very important work.
Thank you. So now we have our first poll question, and remember that the poll is on the homepage of the Whova app. And the question is, do you currently use telemedicine or other technology to assist providers in remote settings? So I'll give just a few seconds to answer. All right, slowly getting some answers. It seems to be, well, so far it seems to be about half and half. We will update, I don't know, we can update you in a few minutes and show you what the results are, but at this point, it looks like probably about 40% yes, 60% no. In the meantime, I'd like to introduce Dr. Nick Dalesio and Mr. Adam Toll. Nick is a pediatric anesthesiologist at the Johns Hopkins Children's Center, and Adam is a serial investor in technology-driven startups. Together, they formed a company, MD AirSupport, that uses technology to remotely provide expertise. This technology was used at Hopkins during the pandemic on COVID ICU rounds, and I think it has great potential to improve the care of children in underserved areas. And we're about to present a brief video that demonstrates their system.
MD AirSupport is a mobile medical telepresence technology that brings you and your network of experts to the patient's bedside almost instantly. The purpose of our company is to extend physicians' ability to provide care from a distance. Patients in remote locations can have access to medical experts who are located far away and who would otherwise be unavailable to participate in their care. Our system improves healthcare delivery and efficiency, allowing a network of on-call experts to be readily available to clinicians in low-resource environments. By utilizing our system to collaborate with remote experts, medical institutions can extend the knowledge and skill of their own clinicians without having to hire more experts. As a result, they can expand healthcare delivery while also reducing costs. To accomplish this goal, we bring expert physician care to patients virtually, utilizing wearable, low-latency video streaming technology operating on a custom-designed platform. To facilitate using technology during clinical care, we designed our system to be very easy to use because we believe the use of technology should focus on optimizing clinical care and not be a distraction. At the push of a few buttons, the clinician in the field wearing our system can alert their pre-programmed clinician network and provide them with a live streaming audio and visual experience of the scene in a full two-way conference. These network clinicians can not only be located within the same building or institution, but can also be, and have been, located continents away. MD AirSupport was originally established to help clinicians through the COVID pandemic as a method to reduce the use of PPE, as well as reduce clinician exposure for those who may be at an increased risk for serious complications from COVID. One clinical scenario where MD AirSupport was originally used was during ICU rounds at the height of the COVID pandemic. An attending intensivist, bedside nurse, and fellow would have direct patient contact. However, consulting services and physicians could interact remotely via the MD AirSupport system worn by the bedside intensivist. In addition, medical institutions utilized our system for medical student education. The COVID pandemic forced medical students to stay home when otherwise they would be participating in their clinical rotations. The MD AirSupport system allowed medical students located outside of the hospital to actively observe and participate in patient interactions, including surgery and bedside rounds. Since the pandemic, the use cases have significantly increased to include pre-hospital EMS systems that have trialed our system to obtain physician assistance while responding to emergencies. Using the MD AirSupport system, EM physicians can perform remote procedural guidance, including ultrasound evaluations, intubations, and even in-the-field ECMO cannulation. Primary care physicians in Kentucky are actively using our system. Family practice residents outfitted with the MD AirSupport system perform in-home medical visits for homebound patients and teleconference with the attending geriatrician that oversees patient care. In Madagascar, nurse midwives were delivering newborns with no pediatricians in the area. Using the MD AirSupport system, these midwives could quickly connect to pediatricians at Johns Hopkins University in Baltimore to obtain consultation should they need it. In Wisconsin, the shortage of senior level hospice nurses has plagued industry that provide these services to patients. Using MD AirSupport, companies can utilize new graduates to respond to patients' home and patient centers, while the finite smaller group of highly trained nurses can supervise and support their visits remotely. The original MD AirSupport system utilizes a wearable Android headset with a simple 3-button interface and a screen positioned near the eye that allows the point-of-care clinician to alert a pre-programmed individual or group of individuals to begin participating in the video conference. After the individuals are selected, a text message and/or email alert is sent to the participants programmed within the system. The receiving experts click on the link, which will automatically join them to the teleconference initiated by the point-of-care clinician wearing the headset. The MD AirSupport portal is a web-based platform that allows your medical system to organize, name, and control the list of experts viewable by the headset wearer. Call schedules can be programmed within the portal, allowing the system to automatically change at predefined times from one expert to the next. At MD AirSupport, our objectives are to continue to optimize and expand the technology to improve patient care while also increasing the ease of use for the clinician. First, we have designed our system and created a mobile app that allows the wearer to alert the expert network from a phone and to interact with them using the cameras from the smartphone, in addition to wearable options. Now, we are integrating a newer, smaller headset camera with the mobile app so that they work together. This new headset has a stabilized lens that creates an even higher quality video stream by better compensating for the wearer's head movements. Next up is integrating other imaging technologies, including vital signs and surgical systems, for transmission to remote experts via our MD AirSupport software. MD AirSupport was created by physicians for physicians to expand healthcare and improve efficiency, all while optimizing patient safety and reducing costs. What is most exciting is that new clinical uses continue to be developed, and we're excited to see all that you can do with our system. To learn more about MD AirSupport and our efforts, you can find us on Twitter at MD AirSupport, on the web at mdairsupport.com, or just email us with the information shown here. Thanks very much.
It's time for our second poll question. Do you have a relationship with one or more rural general surgeons in which you regularly give advice on the care of children? Yes or no? It's looking slightly more no's, but pretty even. Next, we wanted to find out what a general surgeon's practice may look like in an underserved area. Instead of asking pediatric surgeons to tell us what they think occurs, we actually interviewed 2 general surgeons, Dr. Dale Mortenson from Great Falls, Montana, and Dr. Jeff Crooms from Tallahassee, Florida. I think you'll be very surprised to hear the breadth of their practices. Our past APSA president, Dr. John Waldhausen, and 2 members of our committee, Dr. Daniel Robie and Dr. Claudia Emami, conducted the interviews.
Dr. Mortenson, thanks very much for joining us on this APSA meeting. As you know, what we're trying to do is figuring out how to cover children in rural America, and that's why we've asked you here. So why don't we get started? I'll just ask you a few questions. We'd love to hear your thoughts. So first, why don't you tell us a little bit about your practice in Great Falls? How long has surgical care of children been part of that practice?
I started in Great Falls in 1995, and pediatric surgery became part of my practice upon my arrival. 6 months in, our senior partner, who was doing all the neonatal surgery, was in a car accident. His practice unfortunately ended at that point. And so we looked around the room at who had the most recent training, and it fell on my shoulders to take on that responsibility. So I went to University of Colorado, where I had some friends that were junior attendings at Denver Children's, and they took me under their wing as a mentorship or observership for, I think, 3 weeks, where I could attend surgeries and clinics and just reacquaint myself and build my confidence back up so that I could take on some of those cases.
Okay. I know you and I have talked about this a little bit, but could you describe your training in pediatric surgery during your general surgical residency? And then other than what you just mentioned, did you have any additional mentorship or training in pediatric surgery to get where you are today?
So I did 2 years at University of Colorado, 4 at Southern Illinois University. At University of Colorado, I had a 1-month pediatric rotation at the University Hospital, where a lot of my time was spent taking care of ascending cholangitis and Kasai survivors. I did not get a good, like, broad-based general surgery or pediatric surgery exposure at that time, but I was an intern. My 2nd through 6th year at Southern Illinois University was quite different. There was 2 very large community-based hospitals that both had very active NICUs and offered full spectrum pediatric surgery. And all that pediatric surgery there at that time was done by general surgeons that had an interest in pediatric surgery and did it well. And so it was just part of our rotation, our daily, there wasn't a specific pediatric surgery rotation. That's all changed there now. I believe they do have pediatric surgeons, they do it differently. But at that time, I got huge caseload in pediatric surgery and really gained confidence to be able to pursue this in my active surgical practice.
And you had mentioned that you and I trained at about the same time in the late 80s, early 90s, when general surgical training was really significantly different from what it is today. So could you describe the types of surgical cases you perform in children and then what ages of children that you care for?
So I cover the surgical needs of the NICU, which is primarily IV access, but I do gastroschisis repairs, all the acute things, malrotations, annular pancreas, anything double bubble related, atresias, meconium ileus, hernias, of course. That's for the NICU. I don't take on TEFs or diaphragmatic hernias and perforated anus. Those get sent out. Hirschsprungs, I do not do. I had some training in Hirschsprungs, but we never had a pathologist that was willing to, provide us accurate, assessment of ganglion cells. So those get shipped out. But I will do suction rectal biopsies. And NEC, of course, take care of a lot of necrotizing enterocolitis, both in medical and surgical aspects of that. As far as older, when we get beyond neonates, all of the general surgeons here participate in that to some extent. I'm still the most active, but we'll do pyloric stenosis, hernia repairs, manage intussusception, anti-reflux surgery. Do not do pectus deformities. I think those are best sent elsewhere.
So it really sounds like you're doing a very broad range of pediatric surgery.
If I have, the comfort level, and we can keep those kids here and avoid, the disruption in their entire family's life and having to be transferred out for care somewhere else, and sometimes weeks, or in some cases months of disruption. And yeah, it's advantageous to try to take care of these kids here.
Yeah. Are you doing anything minimally invasively, and are you taking care of pediatric trauma?
We do all appendixes minimally invasively. I have a partner that does infant hernias minimally invasively. That wasn't part of my training, but I think he does them very well. I've done anti-reflux surgery down to a year of age. An older kid, we do gallbladders, sometimes in kids. I had an 8-year-old. I took a lap chole, did a lap chole on an 8-year-old last week. Splenectomies are done minimally invasive.
Okay. So what do you do when you run into a situation where you're just not sure of the right answer? Who do you call for a consult? Or how do you handle that sort of thing?
Well, in the early days, in 1993 or 95, when I started doing this, I would initially call my colleagues at the University of Colorado that helped set up that observership. And it was Dr. Bensard and Dr. Carr there at the time. And they were wonderful, helped me through a lot of difficult cases. The problem is that University of Seattle or Seattle Children's was so much closer. And so the referrals all got sent there. So, over time that relationship became more awkward, but fortunately over time, I gained more confidence and experience in expertise. So it became less of a necessity over time. I still do have occasional cases where I want to bounce it off somebody, and I've talked to surgeons at University of Utah and at out in Seattle, and it works. There's always somebody that's willing to talk to you and help you with decision making.
Have there been any limitations to your privileges set by the hospital or by malpractice insurance carriers?
No, not either.
And you did mention that there are other surgeons who perform this sort of surgery as well. It's not just you, is that correct?
That's correct.
So when you retire, do you have a succession plan? Is there somebody who's going to take over the more difficult stuff like the neonates?
Well, I don't plan on retiring for a while, but I do have my youngest partner. He actually had a very similar experience in his residency, and he's more recently trained, but he would rotate with general surgeons in some of the community hospitals. He was in Missouri, I think, somewhere trained in Missouri, and he would go to places like Cape Girardeau where they had active practices, general surgeons doing pediatric surgery, and he gained kind of a similar experience, maybe not as extensive. But I do bring him in and let him assist on cases that I wouldn't normally need an assistant, just so that he can maintain some level of experience. And I have taught all of my partners how to do neonatal cut downs. Some of them are more proficient at it than others, because IV access, having to transfer, a child by air 6 hours away to get IV access is just not ideal. So I prefer that they all know how to do that. But it can be challenging.
So when you're looking for a new partner, do you specifically look for somebody who feels comfortable taking care of children?
No, I think we have enough surgeons here that are willing to take it on, and there's probably always someone around, outside of the call schedule. I sometimes get called, and I have the weekend off, and the NICU calls and says, when are you coming back? Can you, and Sunday night, well, can you stop in and put in a central line when you arrive? And so I'll do things like that, or come back early or leave later, whatever is needed.
All right. Well, we talked a little bit maybe in the last couple of minutes. We talked about the American Pediatric Surgical Association trying to figure out ways to provide care to so many of these children out in rural America who don't have access to a fully trained pediatric surgeon or an adult surgeon who feels comfortable taking care of children. Do you have any thoughts as to how that might be accomplished? I mentioned that, we're working with rural surgery programs in the military, but any thoughts you had in that regard, I think would be very valuable for us.
I think every situation is very unique. It's about the people in the place and what the facilities have to offer and what the local staff has to offer and what their experience is. And if you have surgeons that have some pediatric experience, but haven't been current or lack the confidence, maybe there is a role for some type of mentorship program. It doesn't have to be hands-on. It can be an observership like I had. It would be much more difficult for children's hospitals to bring people in to actually help with surgery. I get it. And I think if somebody lacks that type of experience and needs that type of training, then they probably need to go back to residency. But if they have some experience and there is a need, there's got to be some creative ways to help support them through an observation, vacation, and then the phone a friend, just have contact people that they can get a hold of if they need to discuss a case. I think in my particular situation, we're just so far from any pediatric, full service pediatric hospital that the time that requires to transfer kids out can sometimes, mean life and death. So we have situations where especially on older kids, well, where we have had to do a surgery and then transfer them out because right now we don't have a pediatric critical care rotation. We have pediatric hospitalists, we have neonatologists, but there's this gap. And so, and especially with trauma, so we can stabilize and sometimes do an initial life-saving procedure, but then if they need to be on a prolonged ventilation, they need to get out of here. And then it's critical that there's that contact. But surgeons in situations like this, they have to have some ability to do that. And I guess that's what you're looking for.
Yeah. Well, Dr. Mortenson, we really appreciate your time. I know you've got a busy practice, so we'll let you get back to it. But we really appreciate your taking the time to talk to us today. Thank you.
You're welcome.
Well, welcome, Jeff Crooms. It's nice to have you with us. For the audience, Jeff is a private practice general surgeon. He works in Tallahassee, Florida. He works at Tallahassee Memorial Hospital. And he's part of the Florida State University General Surgery Residency that is centered right there at Tallahassee Memorial Hospital. Jeff and I have been working together for many years. So we're going to launch right into our questions. Jeff, can you tell us a little bit about your surgical practice there in Tallahassee and how long you have been taking care of doing surgical care for children?
I've been in practice here now for 34 years. It's a general surgery practice that covers a broad range from adult as well as pediatric cases. And, that ranges from, cancer surgery, obviously, and has progressed laparoscopically, robotically as well. Children have always been a part of the practice since 1988. When I came, there's never been a pediatric surgeon in Tallahassee. So I felt like that I was well trained, and I certainly have to thank Dr. Joe Tepes for that. Joe was my mentor in my residency, and of course he was trained at Johns Hopkins under Dr. Haller, and Joe taught me a tremendous amount and was very helpful to me when I needed consultations, just as you have been, Dan, since you were in Jacksonville and close to us.
Wonderful. How about additional training that you received or mentorship once you finished your residency?
Well, I did not have any other formal pediatric surgical training after that. And of course, I've, during my time have remained active in SAGES as well as courses at the American College of Surgeons to keep up as far as the advances in general surgery. And with that, some of the minimally invasive procedures have, of course, moved over to children as well, and we've been able to do some of those.
So can you describe for us some of these cases that you perform in children? Give us some examples, whatever you'd like to tell us.
Sure. Well, certainly, we do have a level 3 neonatal nursery here. So if there are lines that need to be put in, Broviac on a 24-weeker that they can't get IV access, then certainly they'll call me for that. I have done with enterocolitis, perforated bowel in the neonates, and even some atresias that were been present that were not able to be transferred out. Of course, that goes over to younger kids for pyloric stenosis, inguinal hernias. Just the other day, we had a 10-month-old who came in with an intussusception. That was about 99% reduced radiographically. The child looked good. I elected not to go to the OR that night. The next morning, we repeated some films, tried another reduction, even though the child clinically looked well. And then we did operate on that child and had a ileocolic intussusception, which was a long polyp with two types of ectopic tissue, pancreatic and gastric, certainly occurring at where you would expect a Meckel's, although it didn't look like a true Meckel's at that time. And I did try that procedure laparoscopically, was not able to reduce that. And of course, then I did that open. And my experience with intussusceptions are about half the time I'm able to do it laparoscopically, and the other half I'm not able to do that.
Jeff, how are you doing your pylorotomies?
All of my pylorics are done laparoscopically. It's been,
I can't tell you how long it's been since I've done an open one, but I've been fortunate to have done all of those over the last several years, many years, laparoscopically.
And can you tell us just briefly in the next few seconds about your anesthesia support?
We do have two pediatric fellowship trained anesthesiologists. Although they're not always in my cases, I do have an excellent nurse anesthetist who's been here for almost 30 years as well, and she enjoys doing pediatric cases. And so I always request her when I've got to do a child, and that is extremely important, as well as having the other support from the neonatologists and pediatricians in taking care of these kids. That certainly could not do that alone.
Claudia, please proceed.
Dr. Crooms, I am a private practice pediatric surgeon too, so I enjoy private practice. It's good to chat with you. I had a couple of kind of more practical questions since I'm involved in credentialing and privileging at my hospital. Have there been any changes as you go through the process of getting recredentialed about what age group you can do and what are the requirements? Has the state of Florida changed any of those?
Not to my knowledge. Certainly at our hospital, I have not had any issues in being recredentialed. There is not anybody else who can do some of the cases that I do. And there certainly are cases that I make the call that, hey, this is a case that is best transferred to a children's hospital or where we have a pediatric surgeon. But there's not been any issues for me as far as recredentialing here or even my malpractice insurance. I've not had any issues in the type of cases that I do.
Do you think if a younger general surgeon would come and let's say be your successor, would that person have any problems in the current environment for A, credentialing, and B, privileging? Because in your case, it's kind of a case of being grandfathered into doing children's procedures since you've been there for over 3 decades, right?
Correct. I think for a new surgeon coming in, if they wanted to do some of the pediatric surgical procedures, that they would have to show that they have been adequately trained and are capable of doing that. So I think that would be an issue in today's environment.
Yeah, because it's the issue of showing adequately trained and then proctoring. Because in your case, you got training in your general surgery that was adequate and you felt comfortable. But I guess, would you see a situation where that person, without having been trained as a pediatric surgeon for a couple of years, have difficulty basically replace you when you get retired?
I think that they would. I do have a young surgeon who's been here, who's in my practice now for 4 years, and he is doing some of those procedures. But of course, when he came, like in doing pylorics and even doing infant hernias, I was in the room and assisted, and so now he's perfectly capable of doing that. I think that it would be very difficult for some of the neonatal procedures, and I can see cases where children would have to be transferred out, or it would be a fly by the seat of your pants operation to try and save, say, a neonate with a midgut volvulus, which we do see. I had one several months ago that I talked with Dan about in doing that case, and that's a child who obviously probably would not survive, or would, stand a high chance of not surviving if they had to be transferred 2 to 3 hours away.
So I guess the hospital, just going along the line of the practicality. So I'm assuming that there's a proctoring requirement, and this younger surgeon met those requirements doing those cases with you. So when they're on call, would they do emergency pediatric cases? Like if there's a, incarcerated inguinal hernia, would they be able to do it?
Yes, ma'am. I think that they would be able to do that. If I'm in town I'm usually called.
I see. So you're the backup that's always there.
Unless I'm out of town, yes.
I see. Has there been any risk management issues related to that in the 3 decades that you've been there taking care of kids?
No, there is not, to my knowledge.
What can APSA do? What do you think the American Pediatric Surgery Association can do to aid rural surgeons, or in your case, not so rural, but by yourself, to promote the delivery of quality and safe pediatric surgery care in communities without a pediatric surgeon?
Well, I think that certainly for a surgeon, it would be, is there a way to get some extra training? Whether that's a 1 month, 2 month, 3 month mini boot camp with Dr. Emami as a private surgeon, as yourself, to have someone come and spend 2 or 3 months with you and being more comfortable with taking care of children. Now, or is there a mini fellowship of 6 months to a year if someone wanted to do that? Those would be some options. The other thing that's as important though about that is, again, as we mentioned a little bit earlier, it's not just me as a surgeon. You still have to have someone from an anesthesia point of view that is comfortable putting a child to sleep. I mean, I have had calls from outlying communities say we have no one that is comfortable putting this child to sleep, even for a pyloric or a hernia. And so those babies or children are transferred to us. And likewise, it depends on your level of nursery too, as to what's going to be available to take care of those infants.
Well, Jeff, I think our time is up. Thank you, Claudia. We really appreciate it, Jeff. You're a great guy, and I don't think you should retire. So if you
should work forever. Claudia.
Well, I appreciate that. My pleasure. Nice to talk to all of you.
Yes, you have a great day.
All right, you too.
So this leads us into our third polling question, which is, if afforded the opportunity, would you be willing to participate in the training of rural surgeons? And so we'll give that a second to get some responses. And at least so far, it looks like the overwhelming response is yes, that our members of our organization would be willing to do so. So finally, we'd like to introduce another member of our committee, Dr. Anthony DeRoss, who will present our committee's efforts towards developing pilot programs to provide pediatric surgical training to general and rural surgeons using the curriculum developed by the APSA Education Committee.
Do you guys have the, oh, thanks. All right, thanks, Abigail and Sam. And thanks for allowing me to talk about the rural surgery training program, the next steps. So as many of you are aware, the Right Child, Right Surgeon initiative recognized a potential gap in care for rural and underserved pediatric patients in locations without pediatric surgeons. And I want to stress the term underserved because there are many pediatric patients who lack access to pediatric surgeons who live in areas that are not, quote, rural. The Rural Surgery Training Program initiative was designed to provide additional exposure to pediatric surgery through a training program focused on general surgeons' needs and clinical environment, as well as to develop mentorship opportunities for those surgeons. The APSA Education Committee is actively developing a rural surgery curriculum. This training program initiative would be aligned with that curriculum. Program goals include increasing access to care for children in rural and underserved areas, improving knowledge of common pediatric surgical conditions encountered by general surgeons, and enhancing communication and referral patterns between pediatric centers and providers where children live. This initiative identified 3 primary focus areas for pilot program development: administrative requirements, curriculum requirements, and site requirements. Potential candidates for this training would include general surgeons in underserved areas who have completed general surgery residency, general surgery residents interested in rural surgery, and military general surgeons. And we wanted to highlight critical care training as a model where trainees might be either in residency or post-residency when completing that training program. Trainee compensation would be the responsibility of the sponsoring institution which would need to develop a comprehensive package commensurate with the training level of the individual. And this may be covered by the residency program in circumstances, for example, when the trainee is still completing their general surgery residency. Malpractice coverage, again, would be the responsibility of the sponsoring institution, and this may vary also upon the training level of the individual. With respect to credentialing, trainees who have completed residency will be credentialed by the sponsoring institution to perform appropriate core general surgery and trustable professional activities, or EPAs. If trainees are simultaneously matriculated in a general surgery residency, credentialing will be included in the training credentials of the general surgery training program, and EPAs will be conducted under the supervision of designated program faculty. The program director would need to be a practicing pediatric surgeon credentialed by the sponsoring institution and who maintains current certification by the American Board of Surgery to practice pediatric surgery, as well as who is approved by the Graduate Medical Educational Committee of the sponsoring institution. Applications for the training program would be reviewed and selected by a committee within the training program. For completion and evaluation requirements, faculty would be required to directly observe, evaluate, and provide feedback to trainees during each rotation or assignment. Operative data would be verified and reviewed at regular intervals. Summative evaluations, final evaluations, and achievement of milestones and clinical competencies would be documented upon completion. We think that a flexible option for program completion would be important to accommodate individuals and their specific timing of training, so that training might be completed in one continuous segment or in blocks over an extended period of time. With respect to the actual clinical curriculum, the curriculum would define a minimum number of procedures required for completion of the program, and this list is by no means all-inclusive, and the numbers certainly are subject to revision as the pilot program process continues to be refined, but trainees would be expected to be competent upon completion in handling conditions like appendicitis, inguinal hernias, abdominal wall defects, the initial management of those, trauma evaluation and resuscitation, neonatal bowel obstruction, central venous access, gastrostomy tube management, cholecystectomy, intussusception, circumcision, and testicular torsion in undescended testes. The didactic education portion would involve using the current handbook being created by the APSA Education Committee, supplementing with reading curriculum, lectures on core pediatric surgical conditions, and online resources. Providing opportunities for experience with other pediatric surgical specialties like critical care, radiology, urology, and ENT would also be included. Additional educational opportunities would include developing mentorship programs between trainees and pediatric surgeons, participating in morbidity and mortality conferences and case reviews, offering pathways for continuing medical education, providing education for training ancillary staff like nurses, ED personnel, and social workers who would also be involved in the care of patients at these institutions where these trainees would end up. And improving communication and referral processes for complex cases before transfer, during hospitalization at tertiary facilities, and upon eventual transfer back to local hospitals. So in summary, the Rural Surgery Training Program initiative would improve the surgical care for all children in alignment with the Right Child, Right Surgeon initiative, and develop training programs for surgeons caring for children in rural and underserved areas by establishing core curriculum and training requirements, partnering with the APSA Education Committee, and utilizing the rural surgery curriculum. The next steps involve identifying potential training sites and launching pilot programs. I'd like to give credit to the entire workforce committee for the work that we presented today, with specific work on these slides done by Rob Ricca, Carmen Ramos, and myself. And special thanks to Sam for all of his continued guidance and input, as well as the program committee for allowing us to present. Thanks.
Thanks, Tony. We actually are over a few minutes, so if there are questions, I'm sure the speakers will be here for a few minutes and answer those otherwise after the recording. So in closing, I'd like to thank all our speakers. We hope you found the session as stimulating and thought-provoking as we did putting it together. Thank you.